whiteboard so that we get started now. Okay, cool. I'm gonna put the chat over here. So I am gonna be looking back and forth, glancing, because I do want to make sure that I'm following what I said I was gonna do in terms of. Give me 1 second, guys. Okay, cool. Are you guys able to see the whiteboard? Our other residents from different specialties doing an IM rotation have the same expectation as IM resident? No. So like if you're a psych resident, if I was your senior, we understand that you're not a IM resident, especially if you join us later on the year. The expectation isn't the same. So you don't have to worry. Okay. So yesterday we left off on talking about presentations, and we went over the difference between a new admission versus progress note of a patient that you've had on the floor. And the difference really was the one-liner. Obviously, you're talking about when you're presenting a new patient, you're talking about their symptoms as a one-liner when you don't have a diagnosis yet. The whole point of the presentation is for you to really deliver information that is pertinent so that you're able to convince, or not convince me, but essentially kind of allow me to understand your thought process as an attending, for instance, of like, okay, this person thought about these differentials and in his HMP, he asked these questions and he eliminated, or as pertinent positives or pertinent negatives, these questions that would either rule in or rule out a specific diagnosis. That also comes down to the labs, the physical exam, imaging, etc. And then your assessment and plan is really putting it together. So this is the same thinking, regardless of whether it's an old patient or a prior patient or a new patient. When you're talking about objective stuff, I don't want you to give me your own like input. Don't say white blood count was 25, which means in fact he has a sepsis or something. Just read it out, and then assessment and plan is really when you consolidate everything and tell me your thoughts as a problem list. So that's kind of what I focused on yesterday. And so today I really want to talk more about that because I feel like a lot of you guys had questions about that and felt like you guys needed more work on that. So the goal today is to talk to you guys about that. So the way that I approach problems is sorry, give me 1 second. So the way that I approach like problem is, patient gets in. So the way that you might have, let's just walk you through a regular admission. You get the ED calls. Man, terrible writing. So the ED calls you, right? The emergency room calls you. ED calls. Okay. So when the ED calls, you get what we call is you're gonna get a sign out on a patient. So there's basically they're telling you, hey doc, hey, I'm gonna give you sign out. This patient needs to be admitted, and they're gonna tell you exactly why they need to be admitted, basically. Okay, so that's really the goal of sign out. And so I don't know why I can't write anymore. So they'll tell you the story. They tell you the story. They first tell you the chief concern. So it could be many things. It could be shortness of breath, chest pain, generalized weakness, whatever, etc. Right? It could be, and then chronicity, and then timeline. Right? They could tell you the timeline. Oh, and then say like, hey, this patient. They'll give you the one-liner. Presents with X, Y, and C. Right? So that's the ED attending or resident telling you this. And then they'll present basically data. They'll tell you the data, what labs, hey, this is what we did, this is what we think this patient's having. Okay. So what happens here, you need to be honest, is that it introduces bias, right? So what I mean by that is like, when someone tells you, hey, I think this patient has this is kind of, they're presenting you a story and they're trying to convince you that this is what's going on. So it's easy to be like, yeah, I totally agree. But what I want you to do is look at everything objectively, you know, because they're just giving you subjective. They're like, I think this is going on. I think this is what is happening, right? Um, whether it's an attending or a resident doesn't matter. I still want you to go in, and it's gonna be hard because you're already kind of getting a bias because they already told you what's going on. But just kind of go in there with a clear mind, right? So be like, okay, I need to have a clear mind of what truly is going on. So really focus on the chief concern. Okay. All right. So let's focus on chief concern, X, Y, or Z. Okay. And then you're like, so for instance, the big thing is you want to just focus on if the story makes sense. Um, so that's what I would do is initially you want to ask yourself, what is the differential diagnosis for this chief concern for my patient? And then so that's just essentially list everything you can think of, right? And then what is the relative pretest probability based on my patient's age and risk factors? For example, so you know you have someone who's 28 years old, IV drug user, you know, meth use, hypertension, presents with chest pain, right? So it's hard to say. I mean, I don't want to like. It's hard. It's hard to. It could be. You still want to have a wide differential, right? So in this situation, it's so easy for you to think, oh yeah, you know, probably cocaine use caused, you know, demand ischemia or some actual ischemia event, you know, versus ACS. But it could be other things, right? You know, did he have a trauma? You can think of trauma. This is a pneumothorax. Am I missing something? Um, so so don't be biased, but also consider, mm, um, but also consider, you know, risk factors, right? So definitely, obviously, this patient does have high risk factors for acute coronary syndrome, but I also want you to consider other diagnoses as well, right? Similarly, you know, someone someone who's like younger, doesn't have any risk factors, less likely that it's ACS, right? It could be other things that are more common. So determine what is most common based on you know, patients' demographic, age, and risk factors. But consider first ruling out other things, right? So that's really the most important thing is I want you to really consider what's their most common risk factors, but I also want to rule out other things. Okay. So now, so now let's think about what we can do here. So the way that I like to think about it is you have the chief concern. So it could be shortness. Let's just focus on shortness of breath. Um, it could be multiple things. So the way that I like to break it apart is into systems, into organ-based systems. So you could think of brain, you could think of heart, lung, you could think of like the GI system, you could think of renal.
My 10-tab eating techniques was garbage. To be honest, I'm pretty sure it sounds like Australian foreplay.
All right, guys. So you guys can mute yourselves. That'd be great. Um, so then, you know, obviously, so there's brain, heart, lung, GI could include liver. There's renal, vascular. What else am I missing? I think that's pretty much the most. And then there's other things, right? Infectious, right? But that could be included. included into other systems. So, heart, you could think of, congestive heart failure. You could think of pneumonia. This is really simple, right? So just something that anybody can do. GI, you can think of, okay, what could cause them to have shortness of breath with GI? You're like, someone who maybe has a lot of ascites, right? A lot of fluid. And they're not able to pull good tidal volume. Renal, you have volume overload, right? So that's a possibility. Vascular, you think of, multiple other vasculitis that could potentially affect the lungs. So you think of vasculitis, right? So, and then infectious disease, multiple things, right? It could be a lung infection of different causes. And then brain, wait, what if they're like patients are just hypoventilating, right? Um, is there a central cause? Obviously, there might be if it's we're talking about the brain system. So I like to think about it in systems, and then just ask yourself. The second part is that's the first part is forming a differential. The second part is what questions should I ask, right? So the other part is what questions slash objective data can I get to rule in, right? Rule in or rule out diagnoses. So that's kind of the point of you going and asking questions is you're not going to go in there, you're not going to you're not seeing patients just to see patients. You need to have like an objective, a plan when you see patients. And I think as an intern, I was just seeing patients to see patients. I didn't really have a plan. This is going to save you a lot of time if you like think about, okay, forming a differential diagnosis in your mind before you see patients, because you're going to ask the right questions, right? So for instance, for infection, you're going to ask them about any infectious symptoms, productive cough, fevers, chills, sick contacts. For renal, you're gonna try to figure out, does this patient have any renal history? For instance, do they have end-stage renal disease, or are their labs consistent with now a creatinine increase and now they're not making urine? Ask them, are you making urine? Are you having good urine output? A GI, look at their LFTs. Are they have ascites in their abdomen? Heart, are they having pitting edema? Are they having weight gain? Are they having orthopnea, paroxysmal nocturnal dyspnea? For brain, are they altered? How do they look? Etc. Lung infections. Do they have underlying lung problems? Meaning, do they have recurrent infections? Are they a smoker? Do they have COPD? Where if they have underlying lung problems, they could be predisposed to lung infections. Are they immunocompromised? Are they at risk for weird infections like other things like fungal infections, etc. So this is not, I want to just be very clear with you guys. This is the way you think is not what it's expected for intern year. I want to just be very clear. This is something that you will get with more experience. You'll be able to put it all together. But I want to make sure I present this data because I think intern year, it's a, I'm gonna try to mute you guys if that's okay. Give me 1 second, guys. Sorry. All right, sorry about that. If you guys want to talk, let me know. I didn't know that you guys were not muted. I don't know. So anyways, so that's kind of what the plan is for you guys to just get all this exposure so that when you are in intern year, you can always look back on what I'm recording. But this will be something that these pattern recognitions will take time for you to develop. It is not expected for you to know this from the beginning, okay? I just want to be very clear. I don't want to add more anxiety to how much anxiety you probably already feel about starting residency. Does that make sense? Kind of the way that we're thinking about this problem or about the approach? Sorry, I haven't been reading the messages. Yes, okay. And you guys are able to see that what I'm typing, correct? Because some people are saying that they see typing, but they couldn't see anything. Or actually, you guys are able to see it. We see it. We see it late. Okay. The one-liner is the same thing as no, the chief. That's a good question, Waleed. The chief concern is basically what the patient's coming in for. So, for instance, chief concern could be like a patient has shortness of breath for the past week, or patient has had shortness of breath since yesterday, and the one-liner would be 48-year-old is male with past medical history of congestive heart failure with reduced EF, hypertension, hyperlipidemia, who now presents with shortness of breath within the past week. That'll be your one-liner for a new patient. For instance, a one-liner for an old patient, like let's say you already presented the patient and it's like her second day, you already kind of have a diagnosis. You could say, this is a 48-year-old, this is our well-known 48-year-old patient with female patient with past medical history of hyperlipidemia, hypertension, heart failure, reduced ejection fraction, who initially presented with shortness of breath for the past week that was consistent with decompensated heart failure. Currently, we're diarising all these things. So that's kind of like you're putting it together. That's more for patients that you had before. And that's the difference, like I said. Do you present the chief concern and then the one-liner, or do you just present the one-liner? That's a good question. So usually I would present the one-liner. If you're like, chief concern is more like for you when you see the patient, like, oh, the chief concern is this, then you come up with a differential diagnosis. So like, let's say the chief concern is shortness of breath. Like the way that it works is like typically you're admitting patients with your seniors. Let's say you get a call from the ED, you're overhearing the resident, your senior resident get the call. They say, hey, this patient has been having these symptoms. You write down what symptoms, and then you form a differential. And then, like I said, the second part would be what questions would you ask? And again, that's going to take time for you to really have a pattern to rule in or rule out. And then also the objective data of labs or imaging, what kind of labs and imaging are consistent with a diagnosis that you think, which one isn't, so you could rule it out also. And then, but when you're presenting, you don't say chief concern, you just basically say the one-liner with, for instance, this is a 48-year-old patient, female with past medical history of this, who presented with basically the chief concern there. But the past medical history, essentially the way that I would say it is, I'll put it up here since it's related to that. So really, one-liner is patient's, obviously name, age, past medical history, presents with chief concern, basically. You don't say chief concern, you say present with whatever, how long, basically with symptoms, time, like timing of the symptoms. Okay. Does that make sense? Okay, cool. And then the other component would be, now that you have these, is like you have an idea, okay. So you have to have what questions directly can I get in and rule out? So this is something that it's gonna take time for you to really understand and learn. Like the more heart failure patients you see, the more pneumonia patients, you'll have thought patterns of what you should expect to see. Right? And I'll give you kind of some idea at the end, but give me 1 second to just kind of finish this thought. And then here you're gonna say, ask questions. So meaning, what are the pertinent positives or negatives? So you're gonna say, ask them all these questions. Patient shortness of breath, it could also be pneumonia, but it could also be a pulmonary embolism, right? It could also be a pneumothorax, congestive heart failure. It could also be an MI, right? It could be also endocarditis. So you have to think about it. Sometimes all these symptoms could have different, all these diagnoses could have different symptoms associated with it, right? So that's why I mean by pertinent positives. Are they having fevers? Are they having nausea, vomiting, diarrhea, weight gain, leg swelling, right? Any rashes potentially. Sometimes patients who are septic could have weird rashes based on bacteremia. Um, Poor PO intake, uh, you know, poor urine output. And then, um, yeah, so that's kind of obviously there's a lot more questions you could ask, right? But that's really, and also obviously cough, right? If they're having productive cough, productive or not, travel history, any trauma. Are they taking birth control? Sometimes, um, for female patients potentially could cause them to have. Are you guys asking questions or not? Never mind. Um, so those are the big kind of takeaways, is really trying to figure out print positives. And this is not negative. This is just essentially things that you could ask. But there's many more questions you could ask. This is definitely not an exhaustive list. Um, and that each one will kind of give you an idea of this is if they're having fevers. Obviously, it could be pneumonia, it could be endocarditis, it could be many different things. But in general, it moves one thing. So if you, for instance, this is kind of where the art of medicine comes in, right? For example, someone has heart failure, right? And they're compensated, meaning like they were doing really well. Usually heart failure could be caused from non-compliance. They weren't taking their medications. um they diet, volume, they were just volume intake, right? They were just drinking too much, or sodium, which is kind of diet. But also, you also have to realize that heart failure could also be caused by sepsis. They maybe they're tachycardic, and now they have diastolic, they have less diastolic filling time. So just because someone who looks volume overloaded, and now they're like, oh, they're having fever, so therefore they can't be volume overloaded. That's not true. Really, you got to look at the whole picture. The whole picture, right? The whole picture. Just because just one thing, having one, you need to have, um it's like a scale, right? um it's like a scale. Terrible drawing, but you know what I mean. It's like a scale. This is positive, positive, negative, 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 negative. If there's a bunch of negatives, the scale is going to go down. For this is congestive heart failure, right? This is other. So if there's way more negative things, then it's less likely that it's congestive heart failure. But every positive is weighed differently, right? So for example, JVD might be weighed more than effusions in the chest, for instance, right? Because it might be delayed, or a vascular congestion of the chest, because the chest X-ray is always sometimes delayed. Leg edema might be weighed more than some other things, etc. That's where you have to think about what's the specificity and sensitivity of a specific test or exam finding. That's something that I definitely will talk about at a different time. But I just wanted to kind of give you guys that idea. Okay. Does that part make sense for you guys? Okay, let's go on to the next one. Okay. So now let's talk about so that's kind of the forming differential, and I will talk more about that if you guys want me to, but I think I'm gonna move on to the next topic. The next thing is kind of workup, right? The way that So then let's say you get to your assessment and plan. So assessment and plan. So assessment and plan is, you do your one-liner again, but this time you could say, you could say essentially your patient's age, female, male, with past medical history of this, presented with this, and you could say whatever you think might be happening. You could say concerning for pneumonia given these findings, or you can kind of keep it brief concerning for pneumonia, that, and then you could explain yourself on your assessment. So then the assessment is really what it's problem list. Usually we use hashtags when we're presenting, at least when we're writing down our notes, we use hashtags to illustrate like a problem. It's a problem list. And if you're in the ICU, you might have different. We do problem lists on the wards, but and then if you're in the ICU, you're having organ system-based lists. So you start with neural, then you go down cardiac, respiratory, etc. But when you're on the ward, you start with the most important, basically what brought them into the hospital, and that's your number one problem, right? So let's say they came in with shortness of breath, and you presented all this data that was pretty much consistent with decompensated heart failure. You talked about on their exam, they had leg edema, they had a brain natriuretic peptide that was elevated. And what's elevated is typically above 400. That's kind of where it's elevated. I'm gonna make more videos later on, specifically focusing on just of like specific diagnosis. This is definitely not the time to do that, because it's a pretty long talk if I just focus on each problem, each diagnosis. So I want to just give you the bare bones here, but if you're interested, we'll do more videos later about that. But in general, your hashtag will be really, since you don't know exactly 100%, especially when you're presenting a patient for the first time, you want to see what their symptom is. Don't say shortness of breath. Shortness of breath isn't really a symptom. I want you to say, are they hypoxic or are they not? So, so if they're having shortness of breath, are they acute, hypoxemic, hypercapnic, or both, right? And how do you determine this? Well, hypoxemic is basically the SpO2, right? Um, uh, if XpO2 is less than 94%, right? Hypoxemic, and then there's also hypoxia. Um, Actually, hypoxia is this. I apologize. Hypoxia is this. Hypoxemia is blood gas. Oh, sorry, guys. Are you typing? Haven't seen anything since ruling out diagnosis. You need to change the page. He is on page 3 now. Yeah, I'm on page 3. Sorry, I don't even. I'm new to this too. I'm on page 3. So I don't know how much you missed, but what I was saying is that when you're talking about an assessment, if someone's coming with shortness of breath, you need to characterize it. Are they requiring oxygen? That's hypoxia. And if you have a blood gas, their blood gas is low, room air. If their PaO2 is less than 60, that's hypoxemic. And if their SpO2 is less than 92% technically, that's hypoxic. Um, okay. So then you could say, for instance, here, patient has acute hypoxemic respiratory failure, right? Because they have a blood gas. So then you could say, differential, most likely X, and then due to whatever. I usually I don't say all that, but I want you guys to get in that mindset of explaining your thought process in this kind of way, because that's really the part where you grow, is like thinking about each problem, so that when you're presenting a patient, you know exactly how you thought about it, so you're not memorizing how to say things. There's a thought process behind it. So when it comes to acute hypoxic respiratory failure, you're like, okay, I talked about this patient who, I'll give you a different scenarios, who gained weight, has hypertension, he had a little bit, had cardiomegaly, his BNP was elevated. So based on that, you could most likely heart failure. So the way I would present it is acute, his primary problem was acute hypoxic respiratory failure as seen on the ABG. Um, most likely in the setting of newly diagnosed heart failure, or you could say newly decompensated heart failure, um, given his interstitial pulmonary edema on chest X-ray, crackles on lung exam, elevated BMP, as well as pitting edema. Less likely that it's pneumonia since he doesn't have any septic signs, doesn't have fevers, chills. His white count is normal. Pneumonia didn't have any, chest X-ray didn't have any consolidation, suggested for pneumonia. You know, cannot rule out pulmonary embolism, since so things like, for instance, you thought about it, so you're like, okay, maybe it could still be a PE. We didn't do a CT angiogram. We didn't do a DVT ultrasound. So when you come up with a plan, you have things that you haven't ruled out yet. So your plan will be, okay, what's the workup for those things to rule out, right? So then you could suggest, hey, potentially we could do depending on how the risk factors, right? If someone is obese, has COVID, for instance, and you think this is all COVID, but you can't rule out other things potentially, and they have asymmetrical, like, leg swelling, tachycardia, or their oxygenation requirements are just really high, you could consider ruling out for pulmonary embolism too. Um, and there's like subtle things that I'll talk to you guys about. What if you can't get a CTA because patients have AKI, that you can get a DVT ultrasound. And if you see if you see DVTs there, the management will be the same. Um, does that make sense? So the way I would do it is, what's the most likely diagnosis to the least likely? I mean, just keep it common sense. Don't say like, yeah, it's less likely that it's a fracture on the toe. Like just keep it consistent with your differential diagnosis. You don't have to list everything out. Some things are more obvious than others. But just kind of give me like 3 or 4 that you thought about, and that's it. Because if I don't want you to list out like 10 differentials that you thought about. Obviously, you thought about them. Just keep them to yourself, but tell me 3 or 4 that are the most common based on his risk factors that he or she could have, and make sure you talk through the thought process of how you eliminated those. Um, okay. Does that make sense? Any questions on that? Okay. So then, do you guys want more examples, or do you guys feel like you guys understood that part? When presenting assessment plans, do you present all problems, even small things around? So yeah, so the way that you would do it is, the way I like to do it is talk about the primary problems. You could say their one-liner presents with this symptom concerning for this. Primary problem right now is his current acute hypoxic respiratory failure. Most likely, given he has a pretty significant risk factors for, for heart failure. Or let me start from the beginning. You could say most likely consistent for heart failure given findings of X, Y, and C, and you kind of put it together. Less likely this, but I can't rule out that. So that's done, right? And then the next line would be, what's your workup, right? So what's workup? What's your other workup that needs to get done or pending? And then what's the management of what do you think currently, right? So workup needs to get done, pending, and then management. So there's certain things that get done in the ED and that you're probably just waiting around for. Mention those things. And management, what is it? Is he getting fluids, antibiotics, diuresis? He's not getting all that. I'm just giving you examples of different patients, etc. Because that wouldn't make sense if you're giving fluids, antibiotics, and diuresing someone. I mean, it could in certain situations, but this is examples of different patients getting different things. So that's kind of what I would say is, workup, management, and then you move on to the next problem. So this patient might have multiple problems, right? So then you could say, his next problem is, they might be related too, but you still want to mention it, right? So they might, sometimes, they might have decompensated heart failure, and they also have an AKI, right? So then you're like, okay, what is the AKI from? And that's kind of where you have to think about the causes of AKI. Think about what, again, think about the causes of AKI. What could he have that could be causing AKI, and ruling out the other things that he might not have, right? And that's kind of how you present that data. For example, if someone's coming in with heart failure, it could be cardiorenal, and that's a pre-renal AKI. But there's also intrinsic acute kidney injury. There's also obstructive kidney injury. So you got to make sure you say less likely that it's intrinsic. Patient isn't taking any new medications or any NSAIDs that could be causing intrinsic kidney injury. You could say his UA was clean otherwise, and then you could also say a post-obstructive, maybe you bladder scanned him, and that's why it was not post-obstructive. And then you could say about the workup. The workup might, depending on what it is, you say it here. And then sometimes patients have a long list of things. Keep it relevant, keep it pertinent, most pertinent things on top. And then let's say you get onto the chronic problems. The way I like to say is, you focus on chronic problems. So let's say you finish all their inpatient problems, any acute problems here. It could be 2 to 3 things or more. And then you get to their chronic problems. You could say, their hypertension, their diabetes, etc. When you present a case, do you say the one-liner plus concerning for and then differentials with the place and then plan workup? Yeah, so I guess when you say the one-liner, it's only for like a new patient that's coming in, because you're still essentially trying to rule out other things. So that's why you say, there's different ways of saying. You could say suggestive, presenting with X, Y, and Z, suggestive of this, concerning for this. And then you go to your problem and you talk about, you don't say hashtag whatever diagnosis you're thinking. You just say overall their symptom, but you don't say shortness of breath, but you say more of medical severity. So if they're hypoxic, you say acute hypoxic respiratory failure. If they're septic, you could say, sepsis, and say what you think it could be from. And then after, your attending agreed with you, then for the next couple presentations, since it's not going to be a new patient anymore, you'll say the diagnosis. You'll say patient with X, Y, and Z in the setting of decompensated heart failure. So that's the way I like to do it. It's an art, it's a style thing. Every person will have a different way of doing it. But yeah, and then after that hashtag problem list, you just say most likely in the setting of what your primary diagnosis is. You talk about why you think so, and then you say other things that are less likely. And then you do the plan / workup. Yeah. Things that need to get done to roll out other things that you haven't done, or things to continue. Like for instance, someone has heart failure, you want to get an echo, right? If they don't have an echo. So you'll say workup, get an echo. Management will be diuresis, for example. And then you continue with the other problem list, and then you say chronic things like sometimes hypertension, you want to continue their medications. Maybe you don't for certain situations. For diabetes, we don't start their metformin clip. We don't start their home insulin regimen. Potentially, we don't start their oral regimen. We usually do weight-based insulin, and I'll tell you guys how to do that later. So that's something you could say is, could start weight-based insulin while inpatient, and then sugars, you want to control them between 140 to 180 while inpatient. And the reason for that is that you don't want to drop them too low, because hypoglycemia is more serious than hyperglycemia, because of patients could have comas, cardiac arrest from hypoglycemia, PA arrest. Okay. Does that make sense? Do you guys want more examples, or do you guys feel like you guys understood that part? And let me know if you guys want to see anything else. If not, I'll continue to the next topic. Okay, in terms of developing differential diagnosis for chief concerns, do you think the ICU systems-based system superior to Vindicate, etc.? Yeah, I think I like this. I like the ICU systems a lot. Um, Everybody has their own style. And honestly, it comes down to the attending most of the time. Whatever they prefer, you kind of just do what they because you're presenting to the attending. Um, so, but I would say try to do whatever. I think system based is more common. I like that also. Um, I know what you mean by vindicate. It's also another way of doing it. I think vindicate is also a great idea. It's for differential diagnosis though. In terms of for presenting, ICU system is better, like you said. Sorry, I think I misunderstood your question. I know what you mean. Vindicate, I think, is better for differential diagnosis. If you guys don't know what Vindicate is, it's just an acronym to be able to come up with differential diagnosis. You guys can look it up. You got Vindicate and then type in acronyms on Google and you'll find what that means. Okay. Any other questions before we move on to interpreting labs? Okay. So move on to interpreting labs now. Okay. So who here feels like they have a pretty good grasp of labs, understanding labs and all these things? Okay. So there's a, when you're writing your labs, there's like the fishbone way of getting labs. So now you have WC here, hemoglobin, and then you have your platelet, and then you could do INR here, um, or hematocrit here, whatever you want. You have your sodium, potassium, chloride, bicarb, and then you have BUN, creatinine, right? And you have your glucose. So, I kind of already mentioned to you guys that the way I like to kind of keep track of what happened yesterday is having a parentheses. Let's say I'm tracking the white count because someone is septic, they're infected. I like to track what it was before. So, parentheses, whatever value. So when I'm presenting, I say the white count is this, yesterday was this. And then you don't have to say that for everything, just the ones that are more the things that you're tracking. If it's kind of stable-ish, you can say chronic add number, if there hasn't been that much of a change. Are we expected to have memorized the normal ranges for all labs, or is it something you can pick up over time? You pick up over time, honestly. White blood count, is you could think of, it's honestly 6 to like 12 typically. It's normal-ish. Hemoglobin, a lot. Honestly, hemoglobin is something that everybody has some abnormal. It's always going to be abnormal. Just think of normal is obviously abnormal slash normal is between 10 to 12, depending on male or female. Um, and then, but yeah, you're definitely concerned for transfusion. You want to transfuse below, if it's above 7, you want to below 7, you transfuse. If it's below 7.0, if it's below 8.0, and patient has acute coronary syndrome, you want to transfuse above 8.0, basically, for patient who has like an active MI. For trauma, you don't transfuse based off a number, based on clinical, is clinical. So if they're hemorrhaging, shock, you transfuse. There's a massive transfusion protocol that you do. But this is the ward, so you don't have to worry about MTP. Basically, transfuse hemoglobin for above 7 in most cases, except for ACS, which you transfuse above 8.0. This is based on a trial that they did, and the trial did not have trauma patients, so that's why we don't go off 7.0 for those patients. Okay, so basically, um, white white blood count, right? Anything above like 12, you're thinking, okay, this patient has leukocytosis, right? Um, there's leukocytosis that you want to be concerned about. The white count um, also has a differential, right? You have a differential where it tells you, how many lymphocytes, how many PMNs, how many bands, how many eosinophils, and then there's like a calculator that you use. You don't have to do it all the time. What's the absolute neutrophil count based on the PMNs and the white count? I don't know the equation for it. You can go to MedCal. Definitely recommend that Med calculator. MedCal. Just Google it. Type in ANC. You'll just put in whatever the patient has. ANC is really absolute neutrophil count is really relevant for patients who have like chemotherapy, who are septic, or maybe have a history of chemotherapy, and now they're coming in with sepsis. You want to make sure you understand if they have what we call is neutropenia. So absolute neutrophil count that's low, right? And there's different ways of severity. There's mild, moderate, and severe. Um, you know, ANC has different severities, and if you go here, you'll be able to tell. Severe is like less than 0.5, for instance. I won't go over the whole details of it because it's out of the scope of this lecture. But there's different severities for absolute neutrophil count. In general, management doesn't really change based on severity. If someone's really has a really low neutrophil count, absolute neutrophil count, and they're neutropenic, um, then at that point they would be someone who you want to cover for Pseudomonas. That's really the gist of the talk. And then, so does anybody know what sepsis is? Just so we understand, like, so we're on the same page. Who here feels like they understand? Oh, I understand what sepsis is, because it's important for you guys to be able to interpret labs and vitals and all these things. If one person says no, I'll talk about it. If not, I'll move on. And I mean, we're all friends here, so it's okay if you guys don't know. I understand SIRS, but now I'm confused with K-SOFA. K-SOFA is basically like more of a prognostication, like scoring system. Mostly the ED uses it. There's some research that uses it to prognosticate the mortality of someone. You don't have to really know K-SOFA. Just understand that it's what it is. When you're really talking about identifying patients that are septic, you just need to know what SIRS is, like you said. Can we refresh it for sepsis? Yeah, sure. Okay, so since we're talking about white count, let's talk about sepsis. So there used to be so whoever knows, sepsis is basically um, essentially SIRS, which is systemic inflammatory response syndrome, which is basically inflammation that your body has to some specific inciting factor, plus uh, some presumed source of infection, right? So sepsis is basically someone with has some inflammatory response and they have some presumed source of infection. They're septic. So SIRS is basically as a couple. This has to be with temp. Either they're like hypothermic or they have so hypothermic is what's less than degrees, less than like 95 degrees. Yeah, 98, 936. So hypothermia. What's hypothermia? Am I getting it wrong? 98, 95? 96. Yeah, exactly. That's what I thought. 96. So 95.9, let's just say. That's how I remember it. Or greater than 100.4 Fahrenheit, right? Fahrenheit. So this is like either they're hypothermic or they have a true temperature, which is a greater than 100.4. Okay, that's one. Two is heart rate, right? They're tachycardic, right? They're tachycardic. This one is white count. So either it's high, typically greater than 14K, or low, typically less than like 5 or 4. I'm just gonna say 5. I'll just say 4 actually. I think it's 4. Less than 4, basically low. And then would you guys know what the last one is? Anybody know what the last one is? Yeah, exactly. Respiratory rate. So the last one is respiratory rate. So they just say less than 36 Celsius, greater than 38 Celsius. Um, greater than tachycardic. Let's just be more scientific here. Greater than 90. They say that greater than 90 heart rate. White count is less than 4 or greater than 14 to 12, basically around there. I usually use 14. Or you have bands, right? So they have bands. They're basically bands as immature forms of white blood cell counts. That's usually greater than 10%. And then respiratory rate, honestly, this respiratory rate is never reliable. It's always like wrong. So I would just say, are they requiring oxygen? So they're hypoxic, basically. That's usually what I like to kind of think of. Um, Q SOFA is the same idea. Q SOFA, basically, respiratory rate is greater than 22, altered mental status, and then they're like they have hypotension, less than 100 systolic, basically. So it's kind of more limited, but I think it kind of combines a couple things. It combines this idea that sepsis is a spectrum. You have SIRS, and then you have sepsis, then you have severe sepsis. Sepsis is no organ dysfunction. This is the old definition. This is organ dysfunction. So they could be altered, they could have an AKI. So that's one of case SOFA kind of uses that a little bit. It says basically there's altered mental status. So that's why it's severe sepsis. But now the new year 2018, they switched it. So now it really is just sepsis or shock. So basically patients with sepsis with or without organ damage. There's no like difference, or they're in shock, which is MAP less than 65, right? Or 80 or like 90 systolic, essentially. Okay. So does that make sense? So that's the white count talk. Um, so now let's talk about hemoglobin. No, honestly, hemoglobin, there isn't much to talk about. A lot of the basically either hemoglobin needs to be transfused or it doesn't. Um, but then there's differentials for hemoglobin too, right? So let's just finish white count. White count, right? So it could be high from, it could be reactive, it could be infectious, it could be inflammatory, um, it could be drug like glucocorticoid. So glucocorticoid / drugs. It could be low from chemo. It could be a little bit dilutional, right? Depending on how much fluid they got. Did I talk about left shift already? I talked about it a little bit. So infection, basically, in early signs of infection, you could have something called left shift. When you have immature bands greater than 10%. So your white count might be normal. Sorry, I should say it could be normal, and you could still have a left shift. Or it could be high, you could have a left shift. So that could be early signs of infection, basically. Okay, so delusional chemotherapy, patient could also be infected, right? Infection like neutropenia. Okay, so that's kind of the most of things that you have to know for now. Obviously, you'll learn more as you go. But if you feel like if you know those things, I think you'll be okay. But the most important thing is glucocorticoid. If you give like steroids to anybody, your white count's gonna go up. It's also gonna decrease the eosinophil count also. Cool. So let's talk about hemoglobin. So it could be multiple. Hemoglobin is important because hemoglobin could drop for many different reasons. It could drop from because of sepsis. Could drop from because they're bleeding clearly. Um, so what helps kind of know, obviously you guys remember this, if it's normocytic, MCV. Um, so you look at MCV to tell you if it's low, high, or normal, and they'll tell you basically if it's normocytic, normocytic or not. Sorry, so I know the 7 gram per deciliter rule for transfusion, but I recently heard about the 10 milligram per deciliter for people with MI. Not sure why. I haven't heard about the 10. That seems like a lot. There's the 8 for MI, which that one is for sure something that we do. I don't know about the 10 though. Um, but was really the most important thing is the transfusion goal that I mentioned. Um, but there's also let's just talk about it individually. So there's high, normal, low. So what would make hemoglobin high is you have polycythemia, polycythemia, which could be caused from multiple different things. Patients who's a high altitude, right? Who lives in high altitude places, who smokes. There's also versus polycythemia vera. That's more like that's not benign. So if you think of that's more of a malignant pathology. Um, you could have that's kind of major, really the big thing for high. Obviously, someone who's also taking steroids could have polycythemia. Normal, it's normal. Low, someone obviously could be bleeding, right? Upper, lower GI doesn't matter. Internal, you could have reactive um, from like sepsis. Causes bone marrow suppression. You could have, iron deficiency, anemia of chronic disease. You could have, chemotherapy that's induced, right, by chemotherapy. Um, you could also have something called uh, microangiopathic hemolytic anemia. They call it MAHA. Basically, that's also from, it could also be from sepsis, but usually it's associated with low platelets too. You could also have what's a quick question for you guys. Do you guys remember what is E. coli? E. coli and low hemoglobin? Yeah, exactly. So hemolytic uremic syndrome, right? That is a form of that's also a form of that, by the way. Then you could also have typical HUS, which is like what you guys know of. There's also atypical, in which patients don't. That's E. coli. That's associated with E. coli Shiga basically a Shiga toxin. This one is actually it's a mutation. There's nothing associated with E. coli or with the Shiga toxin. And that also has low platelets, and it is also a form of macroangiopathic hemolytic anemia. So you have schistocytes. Remember schistocytes. So you can get a peripheral smear. You'll be able to find the schistocytes there. You'll have low platelets. It's a diagnosis of exclusion though. So you want to make sure that you rule out other things before you say that. Okay, so that and then normal, obviously, nothing there. Okay, so then let's talk about platelets. Platelets is kind of the same thing, so I won't waste too much of your time. We'll make it quick. So platelets, you have high. This is definitely not an exhaustive list, just so you guys know. Um, you could have reactive from anemia. You could obviously, and then low is, sepsis. So you could have sepsis. You could have what other causes of thrombocytopenia? What other causes are that you guys know of thrombocytopenia? Just list them out if you guys remember. ITP, yeah, exactly. Um, so you said mechanical valves, yeah, mechanical valves. Okay. So exactly. So you have, the way to think about it is decrease production. You have decreased production, so you have bone marrow. Either it's infiltration from like a tumor or infection, right? You could have also viral decreased production from like viral causes, viral infection, HIV, rubella. Um, you could have bone marrow uh, suppression itself from like chemotherapy or radiation actually. Um, and then there's also like genetic. There's like congenital, congenital, congenital problems, which I won't list. There's like a couple of them. You don't have to know. And there's also nutritional stuff, right? With decreased production, vitamin, vitamin B12, and folate, right? Okay, and then the other problem would be increased platelet destruction. Sorry, this is like destruction / use. So the other one was decreased production. This one's more of it being destroyed. And that's what you guys were mentioning, right? Idiopathic thrombocytopenic purpura. So there's ITP, right? There's TTP, thrombotic thrombocytopenic purpura. And then this one typically isolated platelet decrease. This one both platelet hemoglobin decrease. That's the and this is also AMAHA. Remember I told you guys? So you have schistocytes. This is you need a Coombs test. Okay, that's the agglutination test that you need to do. And then also HUS, right? Like you mentioned, DIC. Who knows what DIC is? Disseminated intravascular coagulation. Yeah. So basically, like just really bad inflammation from like sepsis, typically, that causes sharing of platelets as well as increased thrombolysis. Okay, so then drugs too. You have heparin. Mechanical valves. There's HELP syndrome too, just so you guys know. Whoever's OB-GYN. So forth. There's a lot of that's really the excessive hemorrhage, splenic sequestration, like sickle cell disease, cirrhosis. That's kind of the major ones that I can think of or that you should know. So that's pretty an exhaustive list, and I think that's more than what you should know. So that's platelets, right? So now let's talk about that's the whole interpreting a CBC for the most part. Obviously, not exhaustive by any means. There's more things that you could learn. So let's start. You guys started flipping the page. Now we're in page, not sure how, page 5, I think. Okay, so now we're going to talk about interpreting Chem 7. So Chem 7, we'll do it one by one. So let's start with like sodium. So sodium, it's normal is 135 to 145, right? Anything below that, you would call it hyponatremia, right? And anything above that is hypernatremia. You could think of just changes in that has to do with water. It's either water loss or too much water, right? Too much water that's inside or too much water that's been lost. That's essentially what regulates sodium through ADH. I'm not going to talk about every little thing here, but I just wanted you guys to know how to. So when you're looking at a sodium, when you're rounding, you want to look at the sodium and be like, okay, what's the sodium? Oh wow, it's 135. That's great. But then let's say this is like glucose is 500, right? And the sodium is actually you have to correct it for there's corrected sodium. You need to get corrected sodium. And there's an equation that you should know for each glucose. And then the way that it works is you do the measured sodium plus 1.6 glucose. There's also a calculator, by the way. I don't memorize this. I'm like literally looking it up as you guys are. Divided by 100. Glucose minus 100 divided by 100 times 1.6 plus that. This should give you the corrected. Just basically go to Merkel, type it in. If you notice that the sodium is higher than it should be, then you should correct it and report it as such. Like maybe this actually the measured was maybe 150, and you're like something's definitely not right there, right? Because yesterday was normal, now it's 150. Then you should correct it for the glucose if it's high. Okay, so then okay. So then let's talk about potassium. So then I won't go over the details on sodium because of time. I'll make a separate video on that. And then potassium, normal is between 3.5 to like 5.0 basically. So things you need to know is repleting potassium. You want to replete potassium orally if you can. So PO first. Second will be IV, but you can't push it through IV that fast. IV is 10 milliequivalents to change it by 0.1. So if the potassium is 3.0 and you wanted to change it to 3.5, they need 50 milliequivalents of potassium. The option would be PO. So you want to give them like 50 milliequivalents, 50 milliequivalent tab, how many of those are. But IV, 10 milliequivalents via IV takes like 1 hour basically to run. So if you're giving them 40 milliequivalents, it's going to take 4 hours infusion, which is fine, but you have to just know that you can't run it that fast. So you would want to order PO if the patient can take PO. The reason for that is obviously if we give potassium too fast, it could depolarize the, there's a potassium cardiac cells that basically cause them to have cardiac arrest. So you don't want to do it too fast. Okay, so that's kind of all I would say about potassium. Obviously, potassium could be high for many different reasons. I'll save that for a different talk. So we'll talk potassium. We said potassium chloride, right? So chloride, it's always going to be, that's one of those things where like if you get a level of chloride, it's probably going to be high based on the solution that you're giving a patient. And I'll tell you, do you guys know which solution will increase potassium chloride? Yeah, normal saline, exactly. Yeah, so normal saline will increase it a good amount. So normal is 95 to 105. And so, chloride, if you're giving normal saline, is going to be elevated. So it could be high from normal saline itself. It could be low from if someone's vomiting, right? If you're vomiting, you're losing chloride. So it could be low from vomiting / dehydration. Many different. Those are the major causes of it. There's other causes that I won't go over in this video, but just know that normal saline is one of the major causes for high chloride. Okay, then bicarb, right? So bicarb is one of the things that are probably the hardest to really understand. And I'm going to just give you kind of the simple version of knowing what's going on with bicarb. The way that I think about bicarb is, bicarb is essentially made in the kidneys, right? You're able to compensate For respiratory acidosis by secreting, by reabsorbing bicarb, you have bicarb that's reabsorbed in the tubules, the proximal tubules, right? You have sodium bicarbonate anhydrase receptors, the proximal tubules. Acetosolamide affects that. Basically, you have bicarb that gets reabsorbed in the kidneys, in the beginning segment of the kidneys and the proximal tubules. So when someone has respiratory acidosis chronically, then they will start having bicarb that's elevated. Okay. Typically, sometimes in general, there's things that cause bicarb to be low. Things that, in order for you to know what are those causes, we use something called anion gap. So bicarb normal for the normal range for bicarb is 22 to 20. I would say 27, 28, around there. Um, so the first thing you want to look at is, let's say it's high. Sorry, if it's low. If it's low, below that, you already have a metabolic acidosis, right? So you want to ask yourself, is it anion gap versus non-anion gap? Um, and the way to really the best way to know that is by calculating by calculating an anion gap. In order for you to calculate an anion gap, you need a couple things. You need the sodium, right? Minus the chloride plus the bicarb. So that's going to give you the anion gap metabolic acidosis, or so the anion gap. Typically, the normal range is like 12. So that's going to give you a number. Um, if it's high, you're going to have an anion gap metabolic acidosis. If it's below 12, let's say it's below 12, then it's going to be non-anion gap. So below 12, anion gap greater than 12. But you also have to take in consideration that you have to correct it depending on the patient's albumin level. Um, I don't really do the correction often, but if you have the albumin level, you want to sound a little bit more academic, you could get the corrected anion gap. The way to do that is you do the anion gap, right? You get the anion gap, whatever you calculated here, plus 2.5 4 minus the albumin. That's gonna give you the corrected albumin. Corrected anion gap, not albumin. Corrected anion gap. So that you could say, okay, even the corrected anion gap is still greater than 12, so therefore it's an anion gap metabolic acidosis. Okay, and then to know, there's multiple causes. You guys know mud piles? Have you guys heard of that? Okay. Yeah, so there's mud piles has there's another way of saying it. It's cut mud. There's cat mud piles, right? This one is basically a little bit, just a couple things that you're gonna add on to what you already know. So this one is carbon monoxide, carbon monoxide. You have cyanide. There's also congenital heart failure that does it too, surprisingly. And then there's also this is the C part. The A is going to be aminoglycosides. And then you have T, which is I never even seen this. Maybe you work in peds, you'll see it. It's glue sniffing. It's toluene. Um, that's cat. And then mod piles, you guys know. I'm not gonna write all of it down, but methanol, right? Uremia, You have diabetic ketoacidosis, right? Um, acidosis, alcoholic or even alcoholic, um, keto. There's starvation, ketoacidosis. Um, there's also paracetamol, paracetamol, which is acetaminophen. Um, and then there's also iron, isoniazide. I talked about methanol. There's also ethanol, and there's salicylates also, right? Aspirin. So I know there's a lot of random, maybe not as useful for you guys now, but I think it's important to kind of keep that in mind. I'm speeding through this because this is something that you could easily look up. So I don't want to spend so much time on this specifically. Um, so let's just continue on. And then there's also non-IGAP metabolic acidosis. And I'm just going to tell you guys instead of writing things down, just to be more speed, just be more, because the time is running out and I want to make sure I get through all of everything. There's the non-NI-GAP metabolic acidosis, which is from chloride intoxication, meaning you had a lot of normal saline hydrochloride that was given. You have GI loss of bicarb that could give you non-NI-GAP metabolic acidosis, diarrhea, patients who have surgical drains, fistulas. Um, there's also renal loss of bicarb. Someone with acute kidney injury or renal tubular acidosis could also give you an anion gap metabolic acidosis. So just kind of keep that in mind. Um, so now that we talked about Chem7s, CBCs, that was a bicarb. That was a bicarb component of the Chem7. There's the BUN and creatinine. The big thing that you have to know is really what are the indications for dialysis. So there's a mnemonic. Have you guys heard of the mnemonic for indications for dialysis? Okay, so this is the mnemonic for indications for dialysis. And I'll go over it together. So the big one is what do you guys think of A? What's A? Acidosis. So pH of less than 7.1, basically. Electrolytes. Or, basically we're looking here at refractory hyperkalemia. That's really the major one that we're looking at. Typically like potassium above 6.5 milliequivalents per liter. If they're coming in with intoxication. Sorry, my writing here is not the best, but it could be many drugs. Any drugs you want to do dialysis. If they're coming with volume overload, so volume, refractory to like uh, diuresis, or they're anuric, right? If they're not making any urine, they're anuric, ANURIC. That means they're not making any urine. Versus, obviously, this is an important point. What is anuric versus alloguria? Alloguria. Anuric is like no output. Alloguria is like usually less than 0.55 cc's per kilogram per hour. They're making less than 0.5 cc's per kilogram per hour. That's alloguria um, of urine output. And then the other one is the U. That's U. That's uremic. So it could be uremic encephalopathy / pericarditis, right? Um, so that's kind of the most important thing for BUN creatinine. that you can think of. And then obviously for BUN, causes of increased BUN, corticosteroids. I was gonna say steroids, GI blood loss. So if the BUN starts going up, could suspect GI. It could be GI unproportional to creatinine increase, for example. You could think of GI blood loss also, but you could also think of hypovolemia. You could think of renal failure, obviously, and then creatinine. You could think of contrast induced. You could think of pre-renal, intrinsic, post-obstructive, right? Like typically you think of like older patients, male patients, large prostates. You make sure you get a bladder scan. If they have malignancy, you got to make sure they're not obstructing from their cancer. It's important. So that's kind of the major ones that I would think of. There's many times where I got a bladder scan and the patient had like this large bladder and no one else did that, and so it was such an easy fix. But if you don't look for it, you're not gonna find it, right? Um, that's like obviously very short list. There's more things, but based on what you guys really big takeaway would be these things. Um, so I know that it's already 3:36. Do you guys wanna? I have a couple more things. I was gonna talk about X-rays, interpreting X-rays, EKGs, and fluids, antibiotics, but I think that might be better for another time, honestly. What do you guys think? Yeah, next week would be good. Okay. Yeah, I think so too. I think we spent a lot of time already. Okay. Before you guys leave, can you guys do me a favor? I'm gonna copy a survey here. I'm trying to get better. Obviously, this is my first time doing this, so any type of feedback would be really grateful. Um, so I have a survey that you guys can take after this that I posted on the chat. Feel free to leave me any comments. It's anonymous, I think, and even if it wasn't, you don't feel bad about leaving any feedback. I would take it and use it. I think it's anonymous though. Do you guys anybody have any questions before I leave? Was this helpful or was this too much? Is it too much detail? Too much info? Helpful? Okay, cool. Very helpful. Okay, I'm glad. I'm really happy to hear that. Yeah, give me feedback. I'm glad that we're like not finishing everything at once because I think every time that I get feedback, I do a better job, I think. So hopefully next time when we talk about EKGs, chest X-ray interpretation, fluids, antibiotics, I think it'll be much better. So when is the next meeting? That's still I have to determine exactly when. I think it'll be next Sunday, but I'll let you guys know. When do you guys start? You guys start in July, right? So I still have some time with you guys before you start. Orientation is June 13th. Okay. Some orientation. Yeah, I'll have more than enough time for you guys. Um, yeah, the goal is to finish this boot camp in the next coming sessions. I want to finish boards next week and then do ICU stuff for like a one session because it hopefully won't be that long. And then that's kind of it, really. And then the next session will just be questions and answers. Okay, thanks, guys. Thanks to everybody who are doing the survey or who showed up. I appreciate the help. I'm gonna stay here for like the next couple minutes. If you guys have any questions before I close off the Zoom, because I know it was a lot of info today, but I also want to give you guys a break. How do you let us know of updates or announcements on Reddit? I message everybody. So I like spam message. There's like, oh my, how many people? I don't know how many people message me. Close to 300 people message me. So I manually message everybody. So I do that every time. So just so you guys know, it's actually a lot of work. But that's the best way to do it, I think. I don't, instead I could message everybody, email people, but it's just hard to keep track of everything. Email listserv might help. Yeah, it might help actually. But people, I get a lot of new people that join. Sometimes I get like messages, 20 new people every day. So it's just much easier to just message them directly when they message me instead of having to draft a message and add them every time. Well, hopefully you guys enjoyed the. So like right now I have like 82 people that just messaged me while I was doing the live for the link. So I want to tell you guys in the survey I did ask what you guys thought about the course, what feedback you could give me, and also I'm gonna do a much better job. This is like a free. I'm gonna do this for free for you guys. But in the end of the day, I also want to make something with a little bit more flushed out with the feedback you're giving me. I'm gonna buy a better camera, better recording stuff, take better notes, have patient cases and more examples, cases to present. All that will be part of something I call a premium. So in the survey, I do ask you guys if that's something you guys would be willing to buy, having seen the way that I teach, and if it was of higher quality, if you guys were willing, if interested in buying that. And then considering that there isn't really anything else, at least that I know of in the market right now, of how much you guys would be willing to pay for that type of service. It's something that would continue to grow. You know, I'll be posting uh, new recordings every week, every month, kind of thing, with new cases, specifically guidelines and all these things above the intern level, definitely. Will this recording go on YouTube? Again, in case I want to go back on certain points, yes, it will be going on YouTube. I do edit. I don't really edit it. I just cut it off. So like this stuff that we're talking is not gonna go on YouTube. But yeah, that's kind of the plan right now is to do that stuff. Yeah, I'm recording everything because there's a lot of people who are not able to make it. Any questions before I head out, guys? Any thoughts, suggestions?